You guys loved the video we did on high intensity interval training and coronary plaque regression. And when I saw a video pop up on my feed about plaque and exercise, I thought it would be fun if we watched it together to see what else we can learn, whether there are any differences or surprises in this video. It is by Dr. Brad Stanfield. He is a primary care doctor in the UK. Let's take a look.
A study just published reveals a startling relationship that's the complete opposite to what most people would assume. So it found that the most heavily trained athletes were almost 6 times more likely to have plaque developing in their arteries than those who trained the least. Now that of course isn't the story that we'd expect. But what does this actually mean? Is exercise now bad for the heart? Well, to answer that question, we need to go back to 2008 when German researchers examined 108 apparently healthy marathon runners. So these were men over the age of 50 who'd completed at least 5 marathons in the previous 3 years. The researchers found something completely unexpected. They compared this group with another group selected to have the same heart disease risk profile. So in other words, the group were the same in all of the relevant ways, except for running marathons. But the marathon runners actually had a higher amount of hard, calcified plaque buildup in their arteries. The study
So we know that this is true. We've actually been observing this finding in endurance athletes for a long time, many years. And this is an interesting distinction Dr. Stanfield brings up between these papers that he's going to talk about and the paper that I presented a few weeks ago looking at high intensity interval training and the regression of coronary plaque. So I want you to think about the different kinds of exercise that there are, the impact of endurance training specifically versus high intensity interval training, which is much more focused and shorter in duration. And let's see if any of that comes up in his discussion.
authors concluded that we've been making an unwarranted assumption that being a marathon runner means healthier arteries. The numbers here indicated that the opposite might be true, and subsequent studies confirmed the signal. So in 2017, 2 landmark papers were published back to back in the Journal of Circulation. One found elevated plaque in UK Masters endurance athletes despite lower traditional risk factors. Another looked at lifelong exercise volumes in active men around the age of 55 years old. 77% of those in the highest weekly exercise volume had plaque in their arteries, compared to 56% in those with the lowest volume. But there was a silver lining. Researchers noticed that there were differences in the type of plaque present between the more and less active groups. So the more active groups' plaque tended to be calcified. So this type of plaque is more stable. It's less likely to rupture and cause serious problems like heart attacks. Then in 2023, the Masters at Heart Consortium, which is the same Belgian group behind this new paper that we'll look at in a moment, published the most comprehensive study to date. It included 191 lifelong endurance athletes, then another group with 191 late onset athletes, and then a separate group which were 176 active but non-athletic controls, and they were all screened to exclude cardiovascular risk factors. Partly what they found was now expected. So lifelong endurance athletes had significantly more plaque in the arteries. And then there was this bombshell. Unlike the findings from that last study, there was no silver lining. Troublingly, the lifelong endurance athletes, they did not have a less risky form of plaque than the healthy non-athletes. So what is going on here? Why should endurance athletes accumulate more plaque in their arteries, and are they at higher risk of heart attacks?
So I think that what we'll get to is that exercise is not all the same, right? I wouldn't take away from this that exercise is bad. We'll dig into the paper here just a little bit more in a minute, but I want to highlight the fact that we are talking about high-level endurance athletes. When we dig into the study, you'll see that these athletes are spending 6, 8, 10, 12 hours a week in endurance sport. And this is well above and beyond what the average active person is training for. And I think that the stress load is maybe not even about the exercise, but about the recovery. Let's see if that's something we get into.
Well, lying at the center of this puzzle has been a heated debate that couldn't be solved until this latest study. The debate has been what drives this pattern in the studies that we've looked at. Is it a matter of pure training volume? So do we increase plaque when we log too many accumulative hours on the bike or road over a lifetime, for instance? Or is it the intensity level that's the key risk factor instead? Well, the evidence has been ambiguous. Both sides have been able to make a case for their position, but there's been a weak point in the evidence. Almost all of the prior studies relied on self-reported training data. Participants were asked to recall their exercise patterns, and then researchers turned this into metrics like MET minutes a week. We get these numbers by multiplying activity intensity by activity time, and the end result looks satisfyingly precise. But in most of these studies, it's a metric based on surveys and memory, not actual measurements. And we found that recall data doesn't correlate with actual measurements of activity very well. But this new study did something different. It tracked participants using wearable monitors, in addition to gathering the usual self-reported data. So the researchers calculated training load by multiplying training duration by the level of intensity measured by heart rate. And that's how they derived the shocking number that this video started with. Those with the highest intensities had almost 6 times the risk of developing plaque.
I think it's important here to caveat this by saying that even though the original question was framed as, well, is this just duration or is this intensity? The intensity matters, but these, looking at this abstract here, right, we have people that are on the previous screen, they were average age in their 50s. The late onset training group was people who started after age 30. So we're already talking about potentially 20 to 25 years of training versus 30 to 35 to 40 years of training, depending on when these athletes started their endurance sport career. So we're not really going to be able to disentangle the intensity from time, just even though they're all doing so much time. Even lower intensity is having a great impact over that very long duration of time. Does that make sense? Maybe. We'll see.
Interestingly, when they looked at the same participants using the conventional self-reported data, the old method in other words, the association essentially vanished. And this shows how significant the choice of measurement can be. So what does this study tell us about the debate? Is intensity or volume the main driver of increased plaque? Well, interestingly, high-intensity exercise alone without lots of volume, it wasn't linked to high levels of plaque buildup. On the other hand, high volume showed stronger connections with plaque when it included large amounts of high-intensity training. But what does this all actually tell us? Is high exercise volume, especially when combined with high intensity, dangerous for our heart health or not? Well, the answer is a bit nuanced, so bear with me here. First, it's important to notice that the study found more plaque, but it did not find more heart attacks.
This is a huge point, and I was really hoping he was going to get to this, because my interpretation of the older literature that showed higher calcium scores in endurance athletes was they had a disproportionately high level of plaque burden for their level of fitness and for their cardiovascular risk factors, but they were actually still relatively protected from adverse cardiac events based on their, presumably, their fitness. And that tracks with what we all know intuitively, which is patients who are more active are less susceptible to heart attack and stroke. But that means that when you have an endurance athlete, you really can't translate their calcium score or their plaque burden to risk in the same way that we would in the regular population. And so these patients, people, clients are a little bit tricky to manage because we're not quite sure. We know the risk is less, but we don't have enough of them over time yet to know exactly how much less and how that should change our management of whatever risk factors they may have.
The plaque in the athlete's arteries, they were found because they were looking for it using a CT scanner. It wasn't causing obvious symptoms or problems. There's no data here showing that the athletes doing the most training were having more heart attacks. Second point, it's important to keep in mind who we're comparing the most active athletes to. So the comparison group, they're not couch potatoes, they're moderately active. So we're looking at a set of people within the study who are all in relatively good shape. The study doesn't tell us about how athletes in the high end of the intensity and volume spectrum compared to people who aren't active at all. That surely would give us a very different picture. We'd expect the sedentary individuals to have far worse health outcomes. But let's return to the first point. The study found more plaque with high volume athletes, but it did not find worse health outcomes. And that is really the key thing that we want to know. Does the greater plaque burden for the high volume athletes lead to problems or not? And to get a better answer to this question, we need to turn to another study. And this is where it gets genuinely interesting. So a study with over 21,000 participants, they were followed up for 17 years, and it found that high volume exercises were more likely to have elevated measures of plaque, which again matches the pattern, but crucially, they were not more likely to die from heart disease or other causes. So
Sorry, Dr. Stanfield, might have jumped the gun there, but thank you for bringing up that point. That is exactly what we were just talking about. And I think it's hugely important when we are discussing risk because, again, we just don't know how to interpret elevated calcium scores in these patients because, when we are using studies like this, the threshold for endurance athlete is very high. These are patients doing at least 6 hours of running, 8 hours of cycling, or 6 hours of triathlon training per week. But when you have a very active weekend warrior, we don't know, is that truly somebody who is more like this endurance athlete phenotype, or is this somebody who does CrossFit 2 days a week, but has been sedentary for most of their life, and their plaque accumulation is really their inherent risk, and they behave more like the average patient in our population studies, and we need to address it that way, because it's all a spectrum of how much time people are spending with training, how many years they have spent doing this type of endurance or high intensity athletic training, and what their baseline risk is. And I would say we just don't have a great understanding of how to put people in a specific category one way or the other, unless they are obviously a competitive high-level endurance athlete or a evidently sedentary, non-training type of person.
So far then, here's what the data seems to be showing. High levels of intense exercise increase plaque volume, but the additional plaque doesn't seem to correlate with increased risks of death from heart attacks or other causes for these people who exercise. And when it comes to overall health and overall death rates, there still seems to be an advantage gained by those with very high training volumes. So it appears that the downsides to high training volumes when it comes to heart health is offset by other benefits of exercise. But let's try and get practical for a second here. What does all of this actually mean for us when it comes to exercise? Well, exercise is still the most powerful tool that we've got for promoting healthy, long lives. There's nothing in these studies that we've looked at that overturns that. And the data that we've just looked at reinforces that point. Exercise, it still lowers all-cause mortality. This is a classic case where it's far better to focus on hard outcomes like heart attacks and deaths rather than markers like plaque scores. Equally, however, fitness is not an immunity. When we're amongst the most active, this doesn't give us blanket protection from heart disease. If we're in this group of very high volume athletes, these studies suggest that we could still have plaque building up in our arteries. And the right response is not to stop exercising. Instead, it's just that we don't want to assume that just by being fit means that we don't have to worry about other cardiovascular risk factors.
Again, this is a really important point. We still would want to manage risk factors for cardiovascular disease because every year there are very fit athletes who sustain heart attacks, near the finish line of their marathons or their triathlons. So we know that these plaques can rupture, and even though the risk is lower at the population level, for any given individual, we do want to be making sure that we are not causing any excess risk for harm by not treating risk factors just because patients have this great level of fitness and are very active. So again, this is a very individualized patient-provider discussion, and everybody will come to their own conclusion about exactly how much risk they're willing to tolerate and what the upsides and downsides are to managing any specific risk factors. But it doesn't mean you shouldn't manage them. It just means that if you are an endurance athlete and your calcium score is in the hundreds, it's not the same as somebody who has not been an endurance athlete, but it doesn't mean you're immune. It just means that it doesn't translate to the same level of risk. There may still be options to help mitigate that risk, especially if you are continuing to train at a very high level, if your recovery is compromised, if you have a significant family history, whatever the case may be.
So personally, I exercise because the evidence for its benefits is overwhelming. And I also started taking lipid-lowering medications a few years ago, even though I'm only 34 and without any other risk factors. I want to avoid plaque formation as much as possible, especially with this exercise data. It's not a matter of either or, but both. And I aim to get my LDL cholesterol below 50 to 60 milligrams per deciliter, and that is due to the PISA study. And you can get your own personalized health plan to discuss with your doctor here. So for me, I'm male, I'm 183 centimeters, my weight is 83 kg. And then before I went on to cholesterol-lowering medications, my LDL cholesterol was 1.9. So in US units, that is 73. So a bit higher than what was ideal. So the calculator here will tell me that I should consider starting a statin medication. So I started pravastatin at night. That wasn't quite enough to get me to below 50 to 60 milligrams per deciliter. So then I needed to add ezetimibe, and the calculator gave me those recommendations as well. Now, for most people, it's a bit of a shock to
I don't know much about Dr. Stanfield's calculator. That's an interesting thing, and we can maybe dig into that. Put a note down in the comments below if you want a little deeper dive on where those recommendations come from and what you think about it.
learn that exercise might have a downside when it comes to blood vessel health, but health is full of surprises like that. And there's a popular supplement that carries a risk of damaging our blood vessels, and I find my patients at the clinic almost never know about this. So make sure to check out this next video here to make sure that you're not unintentionally doing yourself harm.
So my takeaway from this is that we really need to distinguish between endurance exercise at a very high level with hours and hours of training per week versus what the average YouTube doctor or person in my clinic means when they say they exercise, because I don't think that exercise creates plaque. I think that in general, when we're talking about high level, professional level athletes, it is an imbalance between the training load and their ability to recover. So inflammation may be higher, the endothelial stress on the artery wall, the shear stress on the artery wall, all of these things may be contributing. And we didn't have much of a discussion about what the mechanism would be for why athletes would have additional plaque formation, but that's an important consideration. And again, I wouldn't ever discourage anybody from exercising. It just means that if you are a high level endurance athlete with a lot of training volume and you have evidence of plaque on imaging, we can be a little reassured that your risk is less, but not zero, than your average, more sedentary counterpart in the population. I am going to stop here. We're going to take a little bit of a deeper dive into this paper and see if there's anything else that comes up that is interesting to talk about. So I really appreciated the video that Dr. Brad Stanfield had just shown us about the relationship between endurance, exercise, and plaque formation. So I wanted to just dive a little bit deeper into that study and show that to you guys because I think it's really interesting in some ways, and it's important to understand what the limitations of the study might be insofar as condemning all of endurance exercise. So let's just take a quick look at the inclusion-exclusion criteria and look at those results and see what we want to take away. So the title of this broad study, this is actually the parent study to the one that Dr. Stanfield mentioned in the video. It's called Lifelong Endurance Exercise and its Relation with Coronary Atherosclerosis. And this was published in the European Society of Cardiology, European Heart Journal in 2023. And this is the Master at Heart study. And we'll go through who they included. There's a nice graphical abstract here. I don't like to dwell on the abstract until we've gone through the details of that paper. So let's dive right into the study population. This was advertised to the interwebs, and it was a widely advertised study proposal, and people would write in and submit themselves to be part of this study. Inclusion criteria were male sex only, so no women included, age between 45 and 70 years. Athletes were defined as follows. By questionnaire, cycling 8 or more hours per week, 6 or more hours per week of running, or triathlon, at least 8 hours per week for 6 months prior to baseline. For lifelong and late onset athletes, they began training at less than 30 years of age or greater than 30 years of age, respectively. Non-athletes engaged in less than 3 hours per week of physical activity without prior exposure to endurance exercise. Metabolic equivalent of task, or MET, minutes per week, was calculated as a measure of exercise volumes. And this was self-reported initially. The study that Dr. Stanfield mentioned, they actually go and measured a year's worth of exercise training data using wearable devices, and those data were uploaded to the study coordinators. Exclusion criteria: who was not involved? Medical history of cardiovascular disease, a history of established risk factors for coronary artery disease. So anybody with diabetes, hyperlipidemia, or hypertension was excluded. Any history of smoking was excluded. Body mass index of greater than 27 was excluded. And I don't know exactly why they did that, but they do show us later that they excluded a number of participants for that. They ended up with 605 eligible patients to sample from, or eligible subjects, and they sampled those randomly to get the study population stratified by age groups. So they had one group of age 45 to 53, 154 to 62, and 163 to 70 years. Anything else? Lifelong athletes were subdivided into when they started training even younger than 20 or 20 to 30 years of age, and late onset athletes were 31 to 40 and greater than 40 years of age. So let's go through the CCTA, or the CT angiography information, just a little bit. So these were blinded studies, good, and interpreted using 2016 guidelines for location, stenosis grade, composition, meaning calcified, mixed, or non-calcified, as well as their vulnerability, including positive remodeling, low attenuation plaque, spotty calcification, and the napkin ring sign. Interestingly, I don't really see those data reported elsewhere, but they do report the segment stenosis score and segment involvement score. Those are common metrics that we'll see in other studies. Endpoints and hypothesis. We hypothesized that more than late onset training, lifelong endurance exercise would be associated with a lower prevalence of non-calcified plaques. Okay, so let's go through the results quickly. Actually, before we do that, I'm going to show you their 605 sample participants, 200 lifelong athletes, 204 late onset athletes, 201 controls initially, and then here are their exclusions. They had multiple people in each group excluded for BMI greater than 27, multiple for antihypertensive drugs, and several in the endurance group for medical history. Ultimately, we have just under 200 patients in each group. Looking at the average age, we see that they're in their mid-50s. Weight is 75 kilos, give or take, and BMI is in the low 20s. Resting heart rate, 54, 56 in the endurance athlete group, 60 in the fit but not training group, and looking at LDL cholesterol is in the 120s to 131 in the groups, LDLs in the 60s, A1C is 5.4 across the board, and about 10 to 12% had a family history of coronary atherosclerosis. All right, and then hours of training per week, 10 to 11 in the endurance athlete group and 1 in the non-training group. Okay, so looking at the data here, you can see that we have the CAC score, which is a bit higher in the lifelong group, at least the distribution is wider, more than one plaque, and then looking at plaque type, there is more mixed plaque in the lifelong group than in the control group, but predominantly all of these groups have mostly calcified plaque. Now, when we talk about calcified plaque in the average population, we believe that that represents kind of 20 to 30% of total plaque burden, whereas in this study, we're looking at almost 2/3 of their plaque burden is calcified plaque. So that's a pretty big switch from what we're usually seeing in the average subject in the population. Now we're looking at calcified and non-calcified plaques here, and you can see that the non-calcified plaques are higher in the lifelong group. And this is the surprising finding that Dr. Stanfield had mentioned, because again, our hope would be that endurance athletes will stabilize this plaque, have less likely or be less likely to have plaque rupture events due to all of their fitness, but they are also more likely than the controls to have greater than 50% narrowing or stenosis. So all of this to say, endurance exercise is not protective. It might even be a cause, or at least the absence of recovery and high volume training might be a cause, that's my own hypothesis, for why these athletes are more likely to form plaque. Now, really, it shouldn't surprise us completely that we're seeing more non-calcified plaque as well as calcified plaque in these athletes. And the reason for that is that plaque exists on a time spectrum, and you have to have non-calcified plaque before you get calcified plaque. So if we had these data previously that said we were having increased calcium scores in endurance athletes, well, at some point that had to be non-calcified plaque. And what I wish we had in here was a little bit more of an exploration of just how vulnerable non-calcified plaque was, because we know that that also exists on a spectrum. We have very unstable, lipid-rich, you can think of it sort of like that volcano just waiting to erupt right under the surface. We also have fibrous plaque that is much less likely to rupture. The cap is thicker and it's more stable, less inflamed, and much less likely to rupture. And I think some of that is probably where we'll see some distinctions, but I don't see how any real discussion or exploration of where that might be measured here in this paper. We do have some of this. I'm going to rotate this all for us here. Sorry. So looking at some of these other findings, they're just reporting subset of CAC scores, number of plaques, where those plaques are, Yeah, I still don't see much of a discussion of the vulnerability of these plaques and how lipid rich they are. And this is something that has evolved as the imaging technology has advanced. This may be something that they will choose to do in the future, is to examine for any of these very vulnerable, really lipid rich plaques and whether that is different between different groups. They do say vulnerable plaques here, but they're just talking about two high risk features. They do see some difference here, adjusted difference, lifelong versus control. And it's actually less likely to have vulnerable plaque here in the lifelong endurance group versus the control group. So there were 6 in the controls versus 1 in the lifelong group. That's a 89% reduction in likelihood for having a vulnerable plaque. That's not something that was, really highlighted in the discussion, but at least by Dr. Stanfield. But I think that's a really important point here. Again, we're not seeing an increase in events in these endurance athletes. So I suspect that the amount of really vulnerable plaque is lower, and the amount of vulnerable plaque here is so low that probably we're just not sure, and we're not convinced that this is really reliable just based on the numbers here, but that's my hypothesis. So stay tuned for more information. If you want a little deeper dive on the training load paper where they measured their data and went into more depth on that, let me know in the comments below. We can certainly explore that if there's more interest in it. Until next time, guys, take really good care.